You are muted.
Hello, sir. Good morning.
Yes. We can start? Yeah, good morning.
Yes, sir.
Okay. Good morning. Today our program is a journal club presentation. One is by Dr. Shilpi Haldar, who is a second year junior resident at RKM Seva Pratishthan, Vivekananda Institute of Medical Sciences, and second will be by Dr. Shiraj Mukherjee, who is a first year junior resident at Apollo Multi-Specialty Hospital. So Shilpi, you can introduce me.
Good morning, sir. Sir, am I audible?
Good morning.
Yes, you are audible. Please start.
You are audible.
Thank you. So, good morning, my respected faculties and my fellow colleagues. I am Dr. Shilpi Haldar, second year postgraduate trainee from RKMSP VIMS, is now going to present my topic today is the transversal fixation versus no fixation for open retromuscular ventral hernia repair, a randomized control trial. Now the introduction. The transversal fixation of mesh with percutaneous sutures in open retromuscular ventral hernia repair is a common practice and one currently under debate. Open retromuscular ventral hernia repair with mesh was originally described with use of transversal sutures for mesh fixation, which are purportedly necessary for keeping the mesh flat to allow ingrowth and to take tensions of the midline fascial closure. So it play an important role in hernial recurrence. There are potential downsides to the transversal suture fixation, including increased time in surgery and greater post-operative pain, and little evidence supports that the transversal sutures offload midline tension or improve mesh ingrowth. Here we aim to evaluate the effect of using no fixation on hernia recurrence rate compared with our standard of care of placing slowly absorbing transversal sutures. So now the details of the journal is that it is accepted for the publication February 21 and 2023, and it is published online that the June 21 and 2023. It is in the JAMA Surgery and 2023.1786. The next slide. Now, the aim and objective of my study is that to determine whether the abandonment of the transversal mesh fixation would result in a non-inferior hernia recurrence rate at 1 year compared with the transversal mesh fixation in open retromuscular ventral hernia repair. And second is that to determine the immediate post-operative pain after transversal mesh fixation versus no fixation in open retromuscular ventral hernia. And third one, to determine the quality of life after transversal fixation versus no fixation in open retromuscular ventral hernia. Now, what is the research question and the hypothesis? So now here the question is no transversal suture fixation of retromuscular mesh is non-inferior to transversal suture fixation in open retromuscular ventral hernia repair? And hypothesis is that we hypothesize that the hernia recurrence rate for patients who receive no fixation will be non-inferior to those receiving transversal sutures. Now, the significance of the study is that we know that the transversal mesh fixation in open retromuscular ventral hernia repair has been advocated to reduce hernia recurrence. However, the transversal suture may cause increased pain. So, the significance of the study is to prove that there are no differences in immediate post-operative pain or quality of life. Now, the inclusion and exclusion criteria. The inclusion criteria is that the patients with a ventral hernia defect width of 20 centimeter or less measured intraoperatively during elective open retromuscular ventral hernia with mesh through a midline incisions and fascial closure. and B the age group 18 to 80 years of either sex, and C is the ASA grade 1 and 2. And here the exclusion criteria is a defect with maximal hernia with larger than 20 centimeter, B a midline approaches, and C is the minimally invasive approach, deep bridge repair means anterior fascia not closed and mesh placement in a non-retromuscular positions and parastromal hernia. Now the materials and the methods. After receiving grant support from the Central Surgical Association, the Society of American Gastrointestinal and Endoscopic Surgeons, and the American Hernia Society, and with prior informed consent from all the patients and or their relatives, a total of 325 patients with ventral hernia are enrolled for the study. The study place is Cleveland Clinic Center for Abdominal Core Health. Study design prospective registry-based double-blinded non-inferiority parallel group randomized clinical trial. Study period November 29, 2019 to September 24, 2021. Follow-up completed December 18, 2022. Now, the methodology is that the data collection. The clinical evaluation was conducted by the treating surgeon at 30 days plus minus 15 days and 1 year plus minus 3 months, or additionally if complications occurred. The long-term follow-up was attempted in all patients. Patients are deemed lost to follow-up after 6 telephone calls without a response. Now, the randomization and blinding. The patient are enrolled by treating physicians or qualified research personnel. Randomization was generated by a statisticians and allocation was completed by a local research coordinator. The investigators are blinded until the mesh was placed into the abdomen, and patients are blinded until the conclusion of the study, and the post-operative accessors remained blinded throughout the study period. 1 year radiographic assessment are performed by blinded surgeons. Now the methodology, total 376 patients are taken, and among that the 372 was randomized. Among that the 162 is randomized to fixations and 163 is randomized to no fixations. And among these 162 randomized to fixation, 132 is analyzed, and among these 132 the patients who are under fixations, the 12 they develop the hernia. Among these the 9 by the hernia recurrence index and 1 by the clinical and radiographic evaluation, and among 163 the 137 was analyzed, and among 15 the hernia recurrence seen, and 50 among them the 15 are by the hernia recurrence index and 1 clinical and radiological point of view. Now the patients are also divided according to their sex. The men, woman, age, BMI, diabetes, active smoking, immunosuppression, COPD, and recurrent hernia, history of abdominal wall. And they are divided into the no fixations and the fixation group, and we get that of the p-value according to that. Now the what surgical intervention is taken, after the appropriate synthetic mesh was selected and placed into retromuscular position, the patients were randomized. Those randomized to the mesh fixation group had 8 number 1 PDS and transversal sutures placed through the 3 mm skin incisions in the lateral abdominal wall using a laparoscopic suture passer. The patients randomized to the no fixation group had 8 the 3 mm same counter incisions made at similar sites, and no suture fixation to the mesh was permitted. Here the care was taken to avoid buckling of mesh during fascial closure. Now, what is the main outcome and measure? From the study, the main outcome was to determine whether the no transversal suture fixation was non-inferior to transversal suture fixation for open retromuscular ventral hernia repair with regard to recurrence at 1 year. A 10% non-inferior margin was set, and the secondary outcome were the post-operative pain and quality of life. Now the statistical analysis, all statistical tests were two-sided and p-value less than 0.5 was considered the statistically significant. No adjustments were made for multiple comparisons. Data are analyzed using R version 4.4.0 and R project for statistical computing. No imputations were performed for missing data. An independent data and safety monitoring board reviewed the safety and efficacy of the data at 100 patient intervals. The primary outcome here, the hernia recurrence, was considered a binary outcome, yes or no, reported at 1 year. The secondary outcomes of interest as measured by the NRS 11 and PROMIS pain intensity 3A questionnaires were compared using mean, the standard deviation differences, and tested using the likelihood ratio. Now the results of the study, we a total of 325 adults. Among them 185 were women, the 56.9%, median age the 59, IQ are 50 to 67 years, with similar baseline characteristics are randomized. The 269 patients, 82.8% are followed up at 1 year. Median hernia width was similar in the transfacial fixation and no fixation groups, 15.0, IQ are 12.0 to 17.0 centimeter for both. Hernia recurrence rates at 1 year are similar between the groups. The transfacial fixation, the 12 of 162, 7.4%, and no fixation, 15 of 163, 9.2%. The p-value was 0.7. Recurrence adjusted risk differences was found to be the 0.95% confidence interval and 0.07 to 0.04. There are no differences in immediate post-operative pain or quality of life. The result taken here, according to that of the ASA class 1 or time or median and wound status, the clean, contaminated or contaminated. Transversus abdominis release also performed. EHS classifications, the M1, M2, M3, M4, M5, and L1, L2, L3, L4, and hernia median width is taken and length is taken in centimeter, and mesh median, the width and length and mesh to defect ratio was seen here. These are the references. Now the pain index here, the pain here the pain has been detected by the PROMIS score and NRS 11 score. The PROMIS score is taken from 1 to 5 here. The no pain is the minimum score, and when it is a higher value, then it signifies the more pain here. And NRS 11 score also, it is the at the baseline and post-operative day 1 to 7 and 30 days and 1 year. The score ranges from 0 to 10, where 10 is the worst pain. Imaginable score has significantly difference on POD 1 and 6. The quality of the life measured by the Hercules score, and the score ranges from the 0 to 100, with higher scores representing the improved quality of life and abdominal wall function, and error bars represent 95% confidence interval. The number of patients represents how many individuals provided scores at each time point. So why we do they do the study? The advantages of the study, that there are some certain advantages of the transversal fixation, which is thought to distribute the forces across the hernia repair and help offload tension on the midline, which might provide benefit particularly in the early stages of the wound healing. And also the sutures are thought to help keep the mesh flat between the layers of the abdominal wall to aid with tissue incorporation, and the placement of the suture is promoted to prevent mesh migration in early post-operative period. But the main disadvantage was that the pain at the transversal sites is the most cited reason for fixation advancement here. Also the some suture sensations also seen at the fixation site. After the study, a surprising finding of our study was that there was absence of a difference in pain between these two groups. We know that the transversal suture can be placed without concern for excessive short or long-term pain or prolonged operative pain, in particularly at extremes of abdomen, including suprapubic and subxiphoid hernias, in which fascial closure might not be adequate. Suture can be placed based at the discretion of the surgeon, but in no fixation we can also see that the efficacy of adhesives in the population, but the patients with hernias is notoriously in challenging position did not experience early failure of their repair attributable to no fixation. So now the conclusion and relevance of the study: the absence of transversal fixation was non-inferior to transversal suture fixation for open retromuscular ventral hernia repair with synthetic mesh, and transversal fixation for open retromuscular ventral hernia repair can be safely abandoned in this population. Thank you, sir.
Okay. Dr. Shilpi, am I audible?
Yes, sir.
Yes.
Okay. Number one, you did a good attempt in presenting this topic. This is number one, a good thing. There are a few things to know, and come to the first slide. come to the first slide, please. Introduction. Right. When you write an introduction and when you write a PowerPoint presentation, it is a request that please do not write more than 5 lines per slide. The problem is that if you write like this, there are more than 20 lines per slide. It becomes difficult for everyone to read. Number one is that you are not required to do a copy paste from the material and then paste it here. You are required to understand that what are the things that they have said. Like what they have said is that the transfacial sutures were important for fixation of the mesh. Okay.
Yes, sir.
So
Yes, sir.
that is the main reason but it was associated with pain, and it is also associated with the recurrence of the hernia. So they wanted to see that what happens if we do not fix the mesh. So basically your introduction, the last paragraph of the introduction has a word called as the research hypothesis or the research statement. If you see the last paragraph, however, we aim to evaluate the effect of using no fixation on hernia recurrence rate. So their main primary objective. So this slide in introduction that you are reading in the journal can have the research hypothesis, can have the primary and the secondary objective. So the introduction slide should mention why did they conduct the study. The second slide should be mentioning their hypothesis or the research statement or the question that they have. They should also now have the primary and the secondary objective. Now come to the next slide, please. Come to the next slide. Hello.
Next.
The next slide.
Next slide.
Again, doctor, the issue is that if you have a PDF, the details of the journal, come to the next one, the details of the journal. Right. Again, you have taken a screenshot or you have taken a photo of that one. The issue is that it is not readable. This is the first thing, doctor. Now, remember that you are presenting to someone who needs to read this one. So it is an humble request. Please either write it down so that everyone can read. Number two is that when do you write the word et al in case of a journal article? Hello.
Yes, sir. Yes, sir.
You write the word et al. Now, see, doctor, the
Sir,
issue is that there are
sir,
many authors in a journal, So there may be 10 authors, 20 authors, maybe more. Some of the studies have more than 100 authors. Now the issue is that in those you cannot go on writing the name of first 100 or first 10. So it is usually the rule that the first 3, the primary author, secondary, and the third, first, second, third are written. Thereafter, the rest of them are followed in the simple word called as et al. Okay, so that
okay,
means
sir.
in this one, so as you can see, there are many authors. Number one. Number two is that this is has it been done in one hospital or has it been done in many hospitals?
Sir, in one hospital, sir.
Single hospital study.
The Cleveland
So
Clinic Center, they have mentioned.
Single center study.
So this is a single center study. Next is that what is the name of the journal? What is the
Sir,
name of the journal?
sir, JAMA Surgery.
JAMA Search. Very good. Okay. Which volume of JAMA Search did publish this one?
Sir, 2000. Sir, this was taken from that July and 2023.
Okay. Very good.
June 21. June 21, 2023.
So what is important is now tell me. So if this journal is there, okay, what do you understand by the word called as the impact factor of this journal? Because in your national board examinations, you will be asked about these ones. Okay, see, this is the impact factor means that how many articles from this journal per year are cited by other journals. Okay, so
sir.
this is something that you have to understand, that there are two things that you are asked in your examinations. The reason that we are having this journal club discussion. In your national board examinations, you will be asked about, and in your MCQ exams in future, is what is an impact factor? Impact factor is the number, say for example, this article was published in the year 2023. Now, in the year 2024, let us see how many times other journals in the world are going to cite this journal called JAMA Search. Okay. So, say for example, there are 100 journals.
Okay, sir.
Right. And then 100 journals by minimum 100 times or 100 articles are cited for this journal. So there are 100 journals in the world, not this journal. They cite this journal 100 articles, maybe one article, maybe 10 articles, does not matter. So your citation, so your impact factor definitely will be 100 by 100. That means it will be at least 1. So now this time what happens is that the better the journal is, so definitely the more better the articles will be. So that means better the article seats, the more is the chance they are going to get cited. That means cited means other journals are going to name those articles in their papers. So that is how they usually calculate something called as the impact factor. What is the impact factor for this journal? What is the impact factor for this journal? The impact factor for JAMA is 16.681. So that means it is a very, very high impact factor. Okay. So please remember that JAMA surgery is one among the most highly rated art surgeries or surgery journals in the world. So the impact factor is 6.
How do you find this number? How do you find this number?
The number is done by every year. The number of the journals, number of the articles that are cited is divided by the number of the journals who cite that article. Say, for example,
Yes.
there are 100 journals
Like
which
it,
cite
you
this article.
say 16, na? How do you get the number 16 here?
So 16 here is nothing here. So 16 here, if you go to the internet and search for JAMA surgery,
Okay.
and then they will write on their
Yeah.
internet page or Wikipedia page that what is their present
Okay,
impact
yes.
factor.
Uh-huh.
Okay.
Same with the author also.
Same with the author. Now,
Author index.
for the author, right? So for the author, exactly as Sarah has mentioned, for the author, the thing becomes something called as an H index.
H.
Okay, so please remember this.
That
thing.
was there in one of the OSCE. One of the
Exactly.
OSCE, this question was there.
So please remember that this is not only a theoretical discussion that Sarah and I we are telling you. These are all exam questions. Please remember that H index is given in your National Board OSCEs. That it means that every year, how many citations you have on a personal note. Okay. So
Okay, sir.
this is H index. So please remember that the better the H index, that means the better you are. So whenever you are in a scientific, say you're in a job interview, you are in say anything or in a scientific collaboration, people are going to ask you, doctor, how many publications do you have? Say you have 100 publications. Okay. Now that is not only that. The next time that they are going to ask you is that how many times is your publication cited by others? So that is citations. Then they are going to ask you, so if you are cited this much, so what is your H index then? So please remember that these are the things that you are required to remember. Okay, right.
Okay.
Now let us come to this journal only. Now let us come to this journal, sir. So whenever you talk about this journal, come to the next one, the aims and objectives done. Now very quickly summarize, because there is another presenter. Very quickly tell us what is the basic aims and objectives of this project.
At the basic, here they only wants to find that what is the recurrence rate following now in the general practice we usually give the transversal suture, but there is a post-operative pain is high. So if we don't use the transversal suture, then the post-operative pain will be low and the patient compliance will be good. So just the aim and objective of the journal is that
Actually,
the
Shilpi, yeah.
yes, sir.
Shilpi, the conventional teaching is if you fix the mesh, there will be more pain. If you don't fix the mesh,
Yes.
there is higher chance of hernia recurrence. So that is the
Recurrence,
conventional teaching. So this study has aimed to address these two questions. And they at the end are trying to say that this fixation versus no fixation does not affect either the recurrence
or pain,
or
sir.
incidence of pain is comparable.
Yes, sir.
But I find these patients they have included are all hernia with large defect, and almost all patient has undergone some form of TAR.
Yes, sir.
You see, yeah, we have shown that TAR is 160 to 162 almost.
Yes, sir.
So that the other patient has got a very large hernial defect, and if you see even the laparoscopic repair also, when they do TAR, they place a mesh. It's not a 15 by 15 mesh. It will be very large mesh. If you put do a TAR on either side with a 15-inch gap, it will be very large mesh. And a large mesh, when you place, the chance of the mesh getting displaced is a little less chance. So
Yes.
I was wondering whether this study could have taken the hernia with a smaller defect also, because these are all the patient who has got a very large defect and they have done TAR. TAR means you have to place the mesh up to the lateral cut margin of the transversus.
Yes, sir.
And I think the observation is that these are all large hernias.
Absolutely, sir. So, Shilpi, that means you see your basic things are three. One is recurrence, one is pain and now. Now come to the methodology of the study. Come to the methodology and come to the two study groups. What is this study type?
So prospective double-blind study, sir.
No, doctor. Please understand very simple, blunt things. There are two types of studies. One, either you observe, They are called observational studies. Okay. On number 2, you have intervention. They are called interventional or experimental studies. So they are the two things. Now, if you are
Yes.
observing them, you can have an analytical group. You can have a case control cohort. There is a case group. There is a control group. That is called still observation. And there
Yes.
is another side, something called experimental or interventional. They could
Yes,
be
sir.
randomized. They
Actually, this is a very valid study where you have the double-blinded patients are randomized properly, and this is the study group has a component of intervention also.
absolutely.
Yes, sir.
So that means this is very straightforward and interventional. That means they have divided the patients into two groups. One is a technique 1, one is technique 2. Fixation, non-fixation.
Non-fixation.
So what will this make it? Simple thing. This is an interventional study or an experimental study. And then they have
Yes, sir.
randomized the patients. What kind of randomization? They have randomized by a double-blind technique. So that means
Double blind.
the investigators were blinded until the
And-
mesh was placed into the abdomen.
Patients.
Okay. So that is the point. So please understand this one.
Okay.
Now come to the next step, because you have another presenter. Come to the next one. So this is the method. What are the observations? Now this is a request, Shilpishi, that we cannot read this slide. This is the problem. If you have read this slide, do you have any? So there are two groups. One is the fixation, one is non-fixation group.
Yes, sir.
So an humble request, please make the slides. Either you can write this, or you can type this, or you can take a screenshot from a PDF and then you can put this. So now tell me, what are the two groups? And now come to the next slide. You have the two groups that are compared, isn't it?
Yes, sir.
Come to the next slide. Now tell me, what is the, so these are the two groups, you see. These two groups technically are more or less similar in their patient characteristic. So that
Yes.
means you cannot say that there is a selection bias, that fixation people had less number, non-fixation had more number. So this one is done. Come to the table 2. Come to the table 2. No, this is all done. This is the technique. Come to the table 2. This one. Now can you kindly enlarge this picture? Okay. If you cannot tell me in this table, what are the things in between the two groups that were statistically significant?
Ramana, you noted that time. The average time is almost 5 hours.
Yes, sir. That is the thing.
Complex. Time is the mean time is median time is 332 minutes.
Sir, I cannot see that well. Let me see. Yes, time is 332 minutes, 332 minutes. But the p-value is not significant in that one. So the only one in which the p-value is significant will be, no, none of the groups, fixation, non-fixation. P-value is not significant. Over time, one status. Come to the next slide, Shilpi.
Yes, sir.
The pain and the recurrence rate. Come to that slide. Where is the pain and the recurrence? No, this is not this one, sir.
This is a pain score.
This is the pain score, exactly. So you see, number fixation is 161, non-fixation is 161. Number of patients are this. Number of patients, no fixation, fixation. Can you see that on this one, on this NRS 11 score, the p-value comes to be 0.03 for which is the circle? The circle group is fixation, isn't it?
It's fixation.
Yes. Fixation.
So that means, if you can see, the fixation people on the post-operative up till the day 3, both of them have the same pain scores. From the day 3 onwards, the fixation people have more pain than the non-fixation people. Okay, and that is a statistically significant outcome. Okay, so this is by one score. And on a parallel note, they have shown you that if I use a promise score, again, the black dots are those who have fixation. So if you see the people who have fixation, they have more pain than people who do not have a fixation. Okay, so this is very blunt outcome that we have understood. Okay, so have you understood about this picture, Silpi? Hello? Hello?
Fixation. Yes, sir. Yes.
Okay.
But
Yes,
on
sir.
the
Yes, sir.
but
Sir,
on
am I
the
audible,
chart,
sir?
they are showing
Sir,
that
am I
they are not
audible, sir?
statistically significant.
Hmm.
Yes, you're audible.
Okay, sir. Thank you, sir.
No. Please answer what sir asked immediately.
Sir, I don't get it, sir. Sorry.
From day 3 to POD 10, there is little higher pain score in fixation group.
Yes, sir.
But are these
Yes, sir.
statistically
Yes, sir.
significant?
Yes, sir. The
Sir,
p-value is less than
yes, sir. Because the
0.05.
p-value is less than 0.05, sir.
So that is the reason
But
it
they
is
are
significant.
but in conclusion, they are saying that there is no difference.
Now come to that one. No, sir. If you compare it at 1 year,
Yeah.
again, both the pain scores are the same.
Yes.
At 1 year again, it is same. So that means what is important is that at 30th day, the non-fixation group has less pain than the fixation group. But if you
Fixation
consider a
groups.
long-term follow-up at 1 year, 1 year, both the groups have the same pain score. So that means maybe the result that I will infer is in the immediate post-operative period, that means in the till the 30th day, fixation group has more pain than the non-fixation group, but at the 1 year, both the groups have the same pain. Okay, Shilpi, what is the recurrence thing? Do you have any graph like this for the recurrence?
No, sir, I don't.
15, I think.
Graph. I don't, sir. I don't get,
You have
sir.
mentioned about
from
15
the graph.
recurrences.
Sir, they only mentioned that, but I don't, sir, get any graph.
But they have
This
mentioned
is the
same number.
quality of. Yes, sir.
They mention about come to that result one. Result
Come to that result.
Yeah.
No, again, this is a variable, Shilpi. These are again the types of hernias, what is the time that they took, again those things. The outcome.
Sir, in the methodology side. In the methodology side.
Methodology side, okay. Now, these are the cases included.
The previous,
recurrence is here.
Here, sir, in the last that they have mentioned, only the 9 was according to hernia recurrence index and clinical and radiological.
No, Shilpi, please understand. This one is called as a consort diagram. Okay, this consort diagram means what is
the recurrence rate? 12. 12 in the no fixation and 15 in the
12 recurrences in
fixation group.
Fixation group and no fixation
15.
group at 15 recurrences. So is it statistically significant? 15 and 12.
Sir, they have mentioned that significance.
Acha, and non-fixation group
but conclusion they said there is no it's comparable, non-inferior.
Right. So come to the results.
Sir, here the 12 among 162,
it's not significant. P-value is
7.4%.
Yeah.
So it is not significant, no? 0.7.
They have concluded a similar outcome. They have concluded similar outcome in both fixation and non-fixation group. I think topic.
Right. I think okay. So I think more or less you had an idea about how these comparative studies are etc. done. Okay. So you had an idea about this. So what is important is that that I think you had an idea. So the take-home message should be that what they have done is a type of a randomized controlled trial. This is how randomized controlled trials are done.
Yes.
They had a primary objective, they had a secondary objective. The primary objective was pain, secondary objective was recurrence. And then they found out that there was
Yes.
a difference between the pain score in the immediate, but not in a long term. Recurrence rate was slightly higher in the non-fixation, but that was not statistically significant. Okay, so this is how we do.
Yeah.
So well presented.
So non-fixation is also a valid technique for hernia repair.
Yes.
So that
Okay,
is the
Dr. Siraj. Dr. Siraj, you can start.
Thank you, sir.
You are mute.
Thank
Yeah,
you.
thank you, Shilpi. Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Good morning, sir. Am I audible?
Yes,
you
you're
are
audible.
audible.
Good morning, everyone. I am Dr. Shiraj Mukherjee, DNB Surgery first year resident from Apollo Hospital, Kolkata. My today's journal club presentation topic is Repasa and appendicitis inflammatory response scoring systems are superior to Alvarado scoring in acute appendicitis. Acute appendicitis is one of the commonest reasons for emergency admission. It is still a difficult diagnostic entity, and the management often involves complex decision making as it involves surgical exploration, which utilizes technical, financial, as well as human resources. A quick and correct diagnosis of acute appendicitis with subsequent early appendicectomy can avoid complications arising from perforation. Though radiological examinations, including ultrasound and CT scan, can further aid in making a definite diagnosis and have been reported to have high sensitivity and specificity, it will inflate the cost to the patient, and also the reporting time may further delay emergency appendicectomy. Another worry is regarding the harmful effects of radiation, which is involved in CT scan. Negative explorations can also lead on to longer length of stay in hospitals, higher costs, and added morbidity and mortality. Unnecessary appendicectomies also should be avoided to avoid potential complications such as ileus, which is found in 1.2% of cases, and incisional hernias found in 0.68% of cases. Therefore, a quick and easy method to diagnose appendicitis in a clinical setting, various scoring systems have been developed to aid in the clinical diagnosis of acute appendicitis. The Alvarado scoring system, which was first described in 1986, has remained the most popular scoring system for many decades, as this scoring system has been proven to have very good sensitivity and specificity. The modified version of this is also used globally. Next slide. The newer scoring
Yes, next slide is on.
The appendicitis inflammatory response score, which was first reported in 2008. In previous studies, AIR scoring system has been found to outperform Alvarado scoring system as it utilizes more objective symptoms, while compared to Alvarado, it takes more subjective symptoms. Also, many studies have independently shown the importance of CRP in the assessment of patients with appendicitis. The AIR score has incorporated CRP also as a variable, whereas the Alvarado does not. The Repasa score is another new diagnostic scoring system which was developed in 2008. The scoring system was initially designed for use exclusively within the Asian population, and it is much broader and simpler. It has several parameters which are absent in Alvarado scores, such as the age, gender, and duration of symptoms prior to presentations, which were shown to affect the sensitivity and specificity of Alvarado scoring system in diagnosing acute appendicitis. The three scoring system, though different in having different maximum scores, have some overlapping parameters. It goes without doubt that any scoring system which can improve over the Alvarado scoring system can turn out to be useful in diagnosing acute appendicitis and thus find generalized acceptance. This study aims to compare the predictive accuracy of AIR score and RIPASA, as well as the widely used modified Alvarado scoring system in diagnosing acute appendicitis by comparing them with the gold standard of histopathologically confirmed appendicitis. This is a table showing comparison of the three different scores. As we can see in modified Alvarado scoring system, we take three symptoms, that is migration of pain, anorexia, and nausea, giving a score of 1 point each. The signs, the tenderness of right lower quadrant is given 2 points, while the other two are given 1 point each. An investigation, we take only leukocytosis, which is given 2 points. Total score comes out to be 9. The additional features which are seen in appendicitis inflammatory response score is that we take only two symptoms in account, giving a score of 1 point each. In signs, we classify the uh, type of rebound tenderness and give them appropriate scores. Here, the temperature is given we give a fixed 38.5 degrees Celsius cutoff, which becomes more easier to record. The investigations, which include the white cell count, proportion of polymorpho-neutrophils, and CRP, are also given specific cutoffs, which it is more subjective. Objective. In Repasa scoring, we take additional parameters such as the age and the sex of the patient, the various signs, the Rovsing sign, the guarding, and also the urine analysis. Total of 17 parameters are taken in Repasa scoring. The main objective of the study is to estimate the predictive accuracy of Alvarado score, the AIR score, and the Repasa score against the reference standard of histopathology in patients who are undergoing emergency appendicectomy. The study design is a prospective diagnostic test evaluation. The duration taken was 1 year. The study populations are those with the patients who are undergoing emergency appendicectomy for suspected appendicitis, defined as acute, meaning lasting less than 4 days, non-traumatic right iliac fossa pain, consistent with a diagnosis of appendicitis, that is pain which is associated with nausea, anorexia, vomiting, and fever, along with the clinical signs such as tenderness and rebound tenderness in right iliac fossa, with or without USG findings suggestive of appendicitis. The sample design is the patients who are fulfilling the inclusion as well as the exclusion criteria. The patients who are included are the ages above 12 years undergoing emergency appendicectomy for suspected appendicitis, defined as acute non-traumatic right iliac fossa pain, consistent with the diagnosis of appendicitis. The patients who are excluded from this criteria are the pregnant females, patients with a right iliac fossa mass, patients with a previous history of urolithiasis or pelvic inflammatory disease, and children who are below 12 years of age. The sample size was estimated using standardized formula for sample size estimation in diagnostic test studies where the sensitivity of the new tests was taken from reference studies. The sensitivity of the reference test, that is the histopathology, was set as 100. A score of 7 was taken as high probability of acute appendicitis for Alvarado scoring system, score of 5 for AIR, and 7.5 for Repasa. The patients were monitored from the day of admission until discharge from the hospital. Daily follow-up included the monitoring of vital signs and systemic examination. Histopathological findings on the operated cases were collected and correlated with the scores. Coming to the results, in the first table, we see the comparison of the three different scores, showing the cutoff of modified Alvarado as 7, AIR as 5, and Repasa as 7.5. Clearly, we can see from this that the specificity, and positive likelihood ratio of AIR and RIPASA is more compared to the modified Alvarado scoring system. And AIR and RIPASA have low negative likelihood ratio compared to modified Alvarado scoring system. Seeing the second table, the same inference can be seen, uh, showing the cutoff of modified Alvarado score as 8, AIR as 8, and RIPASA of 7.5. In the whole study, there were total 107 patients taken. Of these, which was 60 males and 47 females. The mean age of the patients were 25.89. The youngest patient was 13 and the oldest was 70-year-old. The overall negative appendectomy rate was found out to be 15.89%, that is 17 patients. The overall accuracy was found to be 63.55% for Alvarado score, 86.92% for appendicitis inflammatory response score, and for RIPASA score, it was found to be 85.98%. This is a ROC curve where we can clearly see that the area under the curve for appendicitis inflammatory response score and RIPASA score is higher compared to the modified Alvarado score. Comparing with similar studies, the overall negative appendectomy rate in this study, which was 15.89%, was lower than those of the similar studies, as shown. Evaluation of Alvarado in a study which is conducted by Schneider on pediatric population revealed a low positive predictive value of 58% only. Study by R. Ole, a systematic review, showed that the Alvarado score accurately predicts appendicitis and performs well as a rule-out criteria for decision making for observation or admission due to its high sensitivity. However, the review also found that the Alvarado score cannot be used to rule in a diagnosis of appendicitis without proper surgical assessment and further diagnostic testing. The World Society of Emergency Surgeons Jerusalem guidelines in 2015 also stated that the Alvarado score with cutoff less than 5 is sufficiently sensitive to exclude acute appendicitis, but it is not sufficiently specific in diagnosing acute appendicitis. In the study by Scott et al., an AIR score of 5 or more demonstrated high sensitivities for intermediate and high-risk patients with appendicitis and also for patients with advanced appendicitis. In a study by Ari Anderson, the AIR score has shown far better results than Alvarado score. The AIR score probably works better in pediatric population than the Alvarado score because the variables which are scored are easy to apply in children. De Saviero suggested that the combination of AIR and Alvarado score might significantly reduce the risk of overall diagnosing acute appendicitis and thus give a reliable diagnostic performance, thus enabling the treating surgeons to avoid the routine use of CT. Nanjodia showed better efficacy for RIPASA over Alvarado in their study. Concluding, an ideal scoring system should work as a tool that speeds up as well as enhances the accuracy of decision making and at the same time saves up on the needs for expensive or potential harmful investigations. The AIR score probably works better in pediatric population than the Alvarado score because the variables which are scored are easy to apply in children. The Alvarado score requires children to identify nausea, anorexia, and migration of pain, which may not always be accurate. To conclude, this study validates that the AIR and the RIPASA have high discriminating powers and outperform the modified Alvarado score. They could aid in selecting patients who require timely surgery or those who require further evaluation. To summarize, the area under the ROC curve for the RIPASA and AIR scoring system was significantly larger than it was with Alvarado system. The RIPASA and the AIR scores are fast and are definitely better in categorizing patients with suspected appendicitis and reduce the need of diagnostic imaging. Overall, a higher sensitivity and negative predictive value and positive likelihood ratio and a lower negative likelihood ratio indicated that the RIPASA score and the AIR scores are much better diagnostic tools than the Alvarado score for diagnosing acute appendicitis in Asian population. The specificity of the modified Alvarado score can be improved significantly with a drop of sensitivity if the cutoff is raised to 7.5. However, the overall diagnostic accuracy would remain the same. In the case of AIR, specificity can be hiked to 100% with a slight gain in diagnostic accuracy if the cutoff is raised to 8, with a significant drop in sensitivity. For RIPASA, the ideal cutoff remains the same as 7.5. The drawbacks which was found in the study are that the clinical diagnosis of acute appendicitis in this sample population was based on the clinical judgment of the surgeon who was on duty, which could have subjective variations. Patients may have difficulty in defining the time of onset of symptoms. Also, different diagnostic modalities like USG used in selected patients in the department could have affected the negative appendectomy rates detected in the study. The sample size is comparatively small, which could attenuate the significance of association. Thank you.
Hello.
Yes, sir.
Yeah. Hi, doctor. It was a good presentation. A few quick points because it is near 9 o'clock. Okay, we'll be ending now. Tell me very quickly, which journal is this?
Sir, Annals of Medicine and Surgery.
Okay. Which year was it published?
So 2020.
No. So where are your slides that have detailed all this?
Sir, I didn't include that.
Okay. So please remember that this
Again,
is not
same observation. It should be not such. Reduce the writings.
again.
Yes.
So many confused slides, many words written. Number two, please remember that this is a journal club presentation. We are interested in knowing the name of the journals, etc. So this is something that you must improve. Number two is that now tell me what is the objectives in a one word, because remember we have time is very short. What is the main objective or primary objective of this study?
To see whether the RIPASA and the AI scoring systems are better than the modified Alvarado scoring system.
Okay, very good. Number two, what is this study type called as?
So observational study.
Okay, very good. Is it a case control or a cohort?
Sir, cohort.
Is it a longitudinal follow-up? Is it a retrospective follow-up? Is it an ambidextrous follow-up? What is the methodology? This, sir, is a cross-sectional study.
Section.
You have not had any follow-up. Your results end immediately when you do an operation to find out an appendicitis, isn't it? So please remember this one. Last questions to ask about is that in the conclusion, you have suggested that the RIPASA and the AIR scores are better than the modified Alvarado. Okay. What is the basis of this finding?
So because the sensitivity, specificity, and the positive likelihood ratio of the RIPASA and AIR are more compared to modified Alvarado. And the in the ROC curve also we can see that the area under the curve is much more higher compared to modified Alvarado.
What are the ROC curves?
Yes, sir.
Next one.
Can you show us the ROC curve picture?
Yes.
So which one is the modified Alvarado?
Sir, the
First
red
one.
line.
Line, it is so small now. Take a chalo.
Yeah.
It becomes difficult one. So, okay. So by this one. Now the final words are that in between the three groups, how could they know that these AIR scores were superior other than the these ROC curves? Well, any other points?
I'm just right. Sensitivity and specificity. Was right. Sensitivity and specificity. Huh.
Very good. Now again, come to that slide of sensitivity specificity. This is the result. So what is the overall sensitivity specificity?
Sir, for Repasa, it is 94.4% sensitivity and specificity of 76.5%.
Very good. And you have something called as a positive likelihood ratio and a negative predictive value. Okay, right. Now the only question is that is the time. This is the last question on my end. What is the difference between these ones?
Sir, in first table, like we have kept the
What is the difference between a positive likelihood ratio?
Yes, sir.
Or how does it differ between a positive predictive value?
So positive likelihood ratio, it is like the probability of positive test which is expected in a patient in the population of probability of positive test which would be expected in a patient without a disease.
Okay, so this is what thing are you said? This is the positive
likelihood ratio.
Likelihood ratio. So what is the positive predictive value?
The positive predictive value is the ratio of patients who are truly diagnosed as positive to those who had previously positive test results. True positive and
Very
positive.
good. So remember that for an DNB examination particularly, this can be given as a one of your MCQs or one of your questions for the exam. Okay, so that is all from my end. Sir, please.
Okay. Okay. And you see the negative predictive value is also important. The negative predictive value, if we compare this Alvarado with the other two, the negative predictive value is higher on the AIR and Repasa score.
Yes.
Because your decision will be based on this, whether you do the appendectomy or you wait.
Yes, sir.
Okay. Thank you, Dr. Manoj.
Thank you, sir. Thank you. Okay. Thank you, everyone.
Thank you. Hello.